Just push the record button for me.
She's in the office.
No, are you gonna upload it?
It's okay. You're popular, Professor.
I am. I was going to say, I'm having a news conference.
Can you tell us about... I'm kidding.
Okay, we're going to continue with Module 6 and fevers. How many of you have ever had a fever? Yeah, so now you need to recall how you felt, because there are phases to a fever, believe it or not. So the first phase is called the onset phase, and this is where your body is attempting to increase the core temperature to a new set point, and that is all governed by your hypothalamus, right? So if you're in the onset stage, you have the sense of shivering, chills, your skin feels cold, and you have vasoconstriction. So the vasoconstriction is what's making you feel cold. There's less perfusion to your skin. The fever increases your heart rate, your cardiac output, your white count, WBC, your leukocyte count, and your oxygen consumption 13% for every degree. So you can see why we try to manage patients' fevers, because they're already sick, they're already compromised, and so if they increase for every degree of a fever, your heart rate, cardiac output, leukocyte count, and O2 consumption, they increase 13% for every degree. So that's fairly significant. And then, because you're feeling cold and you're shivering, what do we usually do? You apply blankets, right, at home. You're cold, so you're just sort of hiding underneath the covers to stay warm and adding covers so that you don't feel that shaking and shivering and those chills. So we are doing the same thing in the hospital. We try not to get the patient to shiver. So we will apply blankets as well to avoid shivering, and also have other interventions to promote the patient's comfort, as well as not having that increased oxygen consumption and that increased cardiac work that is put on the patient. Shivering produces profound physiologic responses. Remember what I mentioned yesterday, what happens if you shiver? It takes a lot of energy, so it increases your oxygen consumption 2 to 5 times the normal rate. Increases your metabolic demand by 400 to 500%. Increases your myocardial work because it goes up 13% for every degree. Okay, your carbon dioxide production is increased as well. And you have cutaneous, the skin, vasoconstriction, and eventual lactic acid production. So if you go into lactic acidosis, if it gets severe enough, you may end up with a cardiac arrest, right? But generally that's not what happens to patients that have a fever. So the first phase of the fever is you feel that called, you have to know what the names of the phases are. So the onset phase is also called the chill phase or the initiation phase, depending on what book you read. So in the onset, you have those chills, you have shivering, you have feeling cold skin, and vasoconstriction. Okay, the next phase is called the plateau phase. So the second phase. This is also called the fever phase. Okay, so the fever phase, the course phase, the plateau phase, this occurs when your body temperature reaches a new set point. And at this point, you feel neither hot nor cold. So you're not feeling that cold and that shivering and that shaking. Patients may complain in this phase of thirst. If you're young enough to then have a sensation of thirst, that's wonderful. Older adults don't have that thirst impulse in terms of they don't recognize that they need to replenish their fluid. The restlessness, the glassy-eyed look that, you know, when you're really hot and the person has that really glassy-eyed look. They will also complain of malaise, complain of weakness. Okay, they will have weakness in terms of muscle strength. You feel kind of like you don't have the energy to lift your arm off of the bed. You have aching muscles as well, and confusion. So the malaise, the weakness, the confusion, those muscle aches are due to protein breakdown. Physiologically, your body's breaking down protein. Why is it breaking down protein? Because you just had a first phase, and what were you doing there? Shivering and shaking, and so you needed a lot of energy. And so where's the body going to find, what's it going to find to break down? Yeah, initially, but then it breaks down the protein. I'm going to check to see how hot it is in here. It's already set at 40. Not the best I can do, I guess. Okay, so if you're looking at this person, they're complaining they're thirsty, they want more fluid, they're restless. What does the skin look like? Yeah, it's very flushed. And what causes the flushed look of your skin? Vasoconstriction is one answer. Does your skin look flushed when you're vasoconstricted, when you're cold? Your skin is flushed because you have tremendous vasodilation. Because with a fever, remember now the fever has set in, your body temperature has been reset to a higher set point. So if your temperature is now 102, for example, the mechanism to cool yourself down is to vasodilate the periphery, which is what causes that flushed skin look. Okay? So you're vasodilated. You have vasoconstriction if you're cold. Now you're hot. Okay? What am I trying to add here in my notes? I think that was pretty much the notes on that. Okay. So you have a new temperature set point, right? The hypothalamic thermostat has set it up, your temperature up to a higher level, and then you have this fever depending on what the underlying cause of the fever is. Remember the causes of the fever and the different types of fevers? So depending on the different types of fever, you may have those different types of points in the daytime where your temp is higher or lower, or consistent or constant temp, whatever type of fever you have. And then the third phase is that flush phase. It's also called the abatement phase or the defervescence phase. Okay, so during this phase, you have profuse diaphoresis. What does diaphoresis mean? Sweating. Profuse diaphoresis. You have decreased or no shivering at this point, and the patient's skin will still appear somewhat flushed during this phase, warm to the touch because of the vasodilation still. What do we call this, like when you were younger, what would you call this part of the fever phase? The fever has broken, they would say, right? So this is the flush or the abatement phase. So, and during this phase, physiologically, the hypothalamus thermostat resets, and it resets to a lower rate, hopefully back to normal. This reset of your thermostat, of your hypothalamus, triggers the heat loss mechanism, and that causes the intense sweating. During this phase, I've had patients whose linens had to be changed every hour. The linens would be soaked and just totally drenched. The pillowcase would be drenched. So pay attention to how comfortable the patient is. If their linens are not dry, then do keep their linens changed so that they have a dry type of bed. The note in here, in severe sepsis, these three phases do not occur. So if they're severely septic and critically ill, you won't see these three phases of a fever. So if you have a patient who's in the flush phase and they have tremendous diaphoresis, what is your nursing role at that point, besides changing the linens and keeping the linens dry? What are they at risk for? Dehydration, so fluid volume deficit, right, would be the nursing diagnosis. And what's that related to? That's could be an as evidenced by. So the related to is the pathophys. What's the pathophys of fluid volume deficit for the patient who is now profusely diaphoretic? What's the related to? We just talked about what's happening. That's the as evidenced by. What's the cause? The thermostat is being reset from a higher set point to hopefully back to a normal set point. And so then the body says, okay, I need to cool down. And how does the body cool down? With sweating. Your role as a nurse is to monitor fluid volume deficit. Because they can...
Stated as easily as the fever broken? Or you need to be...
the related to should always be pathophys.
Okay.
And if you learn pathophys, you will have a much better concept of why things happen. If you know pathophys, you can be an absolutely incredible nurse. If you're just doing things because you learned in Nursing 101 that during the defervescence phase, you have to monitor the patient's fluid balance, and you don't know why, then you have no rationale. Okay, so always know why you're doing things and why things happen, and that's the pathophys. So if you're having fluid volume deficit related to, I think you just said it, thermostat reset secondary to, this person's in this flush defervescence phase, and as evidenced by profuse diaphoresis. They're not shivering at this point anymore. Okay? And what are your concerns with this profuse diaphoresis? Dehydration. So the labs would show, you would review the lab. So electrolytes you would look at, right? So what would you expect to see in someone who has fluid loss? Sodium would be high, H&H would be high, BUN would be, everything's up. Because in the vascular system, you are losing volume. If you lose volume, whatever's in your blood becomes more concentrated, so the values will be higher. Does that make sense? If you have fluid volume overload, all those numbers that I just mentioned will be down. Because there's more volume, it's more dilute. Yeah? Okay. So you're going to monitor those patients' electrolytes. You're going to monitor skin turgor. So you're checking all those things that would cause dehydration. What else would you check? LOC. Because with dehydration, especially older adults, they quickly have LOC changes. What else? The what? WBCs, yes, would show you if they're dehydrated would be high or low? High, okay.
Blood pressure?
Blood pressure, because if you have that much fluid loss, what's going to happen to your blood pressure? It's going to go down. What's going to happen to your heart rate to compensate? It goes up. Okay. So monitor those patients very carefully, and keep in mind that when you or I have a fever, it's just temporary type of thing. We're not underlying. We don't have all of those other things, those comorbidity type of things that many of our patients have. There are some benefits to a fever, and some of those benefits are that it kills microorganisms and adversely affects their growth and replication. When the body becomes too hot, many microorganisms are not in an environment where they can thrive and duplicate, so just having a fever helps to kill off those organisms. It decreases the serum level of iron, zinc, and copper that is needed for bacterial replication when you have a fever. And it also has a tendency for auto-destruction of cells, which prevents viral replication in infected cells. Okay, having a fever also increases the motility of neutrophils, and it facilitates the immune response. It makes the immune response kick in and try to rectify the situation. And then phagocytosis is enhanced, and production of antiviral interferon is augmented with a fever. So normally we don't treat a fever until we get to, usually in the hospital we'll treat at a temperature of about 101. So let it ride and let the normal body systems, the immune system, try to attack whatever it is. But keep in mind, if you have a patient who has been on long-term systemic steroids, we don't let their fever go very high because, before we treat them, we treat those patients at 99 degrees. So why is that? Remember what those steroids did? We talked about it for respiratory patients.
Their production of
Diminishes the production of but which cells? The white cells. Those white cells are what's needed to fight infection. Okay? So if you have a patient who's been on systemic steroids, we will treat that patient's temp when it gets to 99. In addition, you will come across patients who've had transplants. They're not there because they just had a transplant, but at some point in their life, they've had a transplant of some sort. So it could be a kidney transplant, a liver transplant, maybe a heart transplant. They've had some sort of organ transplant. Those patients are heavily medicated with medications that inhibit their immune system. So if you're taking meds, and often they're steroids as well, you're taking those meds to keep your immune system in check so it doesn't reject the organ that you have that was transplanted, then those patients, we tell them that at 99 degrees you had better go see a physician because that's probably equivalent to 101, 102 in someone who has an intact immune system. So that slide that says fever usually is not harmful if it stays below 102 applies to everyone except people who are immunocompromised. It also applies to older adults because they do not have leukocytosis in response to an infection in many cases. Okay. So moderate fever stimulates the immune system. It works better at higher temperatures for the reasons that were on the previous slide. And a fever also serves as a diagnostic purpose. Sometimes patients come in with a fever, and that's the only sign and symptom they have. And so you'll see fever, FUO, fever of unknown origin. They don't know what's causing the fever, but diagnostic studies hopefully will shed some light on why they come in with a high fever. So when they initially come in, FUO, fever of unknown origin. So what kind of tests would we want to run to determine what's causing that fever? Blood cultures? What else? CBC with differential. Chest x-ray, maybe they have pneumonia. What else? UA, maybe they have a UTI, maybe now they have urosepsis. Culture sensitivity of a wound, perhaps. Maybe they have some sort of a boil that's just been festering, and a lot of those boils that look sort of like maybe they have an insect bite initially turn out to be MRSA. Many of them. They think, oh, it's nothing, and then it keeps festering, and pretty soon they feel pretty sick, and that you culture the drainage from that, where they thought was some sort of a bug bite, perhaps, and they had MRSA. What other diagnostic study would be helpful? Anything else? We've mentioned most of them. Chest x-ray, culture and sensitivity, UA, culture of the urine. We talked about the CBC with the differential. So those are pretty much diagnostic studies that we would be considering for patients with a fever of unknown origin. So fevers serve a diagnostic purpose for that reason. You wouldn't have a fever if something wasn't going on, and generally it's pretty indicative you have an infection of some kind. Okay? And again, it should be treated only if it's high enough to produce serious side effects. Generally in a hospital, you'll have PRN orders for a fever to treat it for a temp greater than 101. Some standing orders will say greater than 100. So generally, we're close to 101. Okay? So temperature assessment, the standard of care for a nurse, for nursing care is that if your patient has a fever, has a temperature greater than 99, that you will take your temperature every 2 hours until the temperature returns to normal. You will not see an order for that. That's a standard nursing process on every unit that you're going to work for. Work in, I guess I should say, instead of for. So you take a temp every 2 hours till it returns to normal. In some cases, as you get to the more critically ill patients, you may have to monitor the temp hourly. Okay, because they may have some sort of neurologic head injury, and some of those temperatures go out of control very quickly. So depending on where the patient is, it may be more than every 2 hours. But the standard intervention without, you don't need an order for that. Physicians know that nurses will automatically adhere to that standard of care of patients with a temp, and that is to take it every 2 hours. So you're going to check the skin and mucous membranes to check for dehydration. So the mucous membranes, which ones are you concerned about? The mouth, the oral, the lips, the tongue. Mucous membranes of your eyes, good indicators of dehydration. You're going to assess signs and symptoms and monitor for electrolytes. What are some of those signs and symptoms? When you've had a fever, what are your complaints that you would tell someone about? If you were the patient, what signs and symptoms do you have when you have a fever? Weakness, so that's called myalgia. Aches and pain. Dry eyes. Glassy eyes is an assessment finding that you're going to make. They're not going to complain of glassy eyes.
Oh, okay. Like dry eyes, or their eyes feel hot?
Their eyes might feel hot. They may also have photophobia, that they can't tolerate with a high fever or that light, so they want the room to be darkened. Okay? Headache, common with a fever. The thirst, and not so much in older adults, so you need to offer them fluids. And then do you have a voracious appetite when you're sick with a fever? No. So it's loss of appetite, and that's why we usually say get adequate fluids, treat the signs and symptoms, take some Tylenol for your headache and your muscle aches, right? So treat symptomatically. But generally the appetite is just not there if you're feeling sick. And then observe for behavioral changes. What behavioral changes are you going to see? As the temperature goes up, you're going to see LOC changes, level of consciousness changes. So you'll have confusion if the temperature gets high enough. You'll have disorientation. And what are you going to monitor? We talked about what you're going to monitor, those electrolytes. Okay. So in terms of temperature management, if they're in the hospital, generally it's due to some sort of organism that has invaded one of their systems. So if it's due to an underlying problem, if it's a fever of unknown origin and all those lab tests come back and those diagnostic studies come back, you can zero in on what probably caused that fever. And then we'll focus on relieving that problem. So if it's a UTI, they'll prescribe antibiotics for the UTI. If it's pneumonia, we'll give them some respiratory treatments and respiratory specific type of medication. Fever reduction should be considered if the increase in temperature is severe, so if it's greater than 103 degrees. Up to 103 is not harmful. And then physiological cooling should accompany pharmacological management. How do we promote physiologic cooling? The what?
Pick up some layers.
Take off layers, yeah. Clothing layers, blankets. So if they're still hovering underneath those covers, pull the covers back. Set the thermostat, if the thermostat in the room is at 80, turn it down to what?
72.
72, yeah, 74. What else? Sometimes you put a fan in the patient's room to cool them down. Cold fluids, lots of fluids are very helpful. They can take fluids. Where do you put ice packs? Axillary, back of the neck, the groin, right? Why do we put them in those places? Is it what? Why do we put them in the axilla? There's lots of perfusion, there are lots of vessels. And since the patient is hot and they're vasodilated, that's where the vessels are closest to the skin. Okay, and those large femoral vessels in the groin area, very close to the skin. The back of the neck as well, side of the neck. So sometimes they have like a collar type of thing we would put around the patient's neck. So continue to be aware of the patient's fluid status because they can get readily dehydrated even though they haven't had the defervescent stage. Okay. Antipyretics, the medications we will give for a fever. Antipyretics will lower fever of multiple causes, and then it lowers the fever by affecting the thermoregulation of the central nervous system and by inhibiting the action of the prostaglandins peripherally. The contraindications for giving antipyretics would be not to give aspirin, ibuprofen, and naproxen. It's bleeding disorders, so if the patient's also on anticoagulants, check and see what their PP and their INR are before you give them aspirin or ibuprofen or any of those others, or if they have severe liver disease. Okay, so here's a slide that just lists the different types of antipyretics. You already know the kind of questions we ask. We don't ask the doses. We don't ask the frequency. So don't memorize the page. You're wasting your time. Just know that there are different antipyretics that we give to patients and that ultimately the intent is to lower the temperature. You can look at, they're all antipyretics that are listed here. So you can just see that the dosage has nothing to do, you can't compare doses from one to the next because the dose is specific to the drug. So 325 milligrams of acetaminophen would probably be equivalent to 325 milligrams of aspirin, which is equivalent to probably 202 to 300 of ibuprofen. But ketoprofen would be like 12 and a half. So don't think that that's a much lesser dose. They're just dosed differently. Okay? We should give them with lots and lots of fluids. Some of these meds need to be taken with food so they don't end up with, especially the naproxen, can cause gastric irritation, tremendous gastric irritation. Okay, some patients will get anti-infectives, antibiotics, and depending on what sort of culture and sensitivity has been obtained, will determine the type of drug that will be ordered for the patient. So most of those are either bactericidal or bacteriostatic if it's for a bacterial infection. And then your job is to know that what their allergies are. Every now and then, we used to get patients who would have drugs ordered that we knew they were allergic to. So your patient's going to have an allergy band. And every now and then, you'll notice that they're getting something that they're known to be allergic to. So now what? Call the doctor and verify that the patient has a band on, an allergy band that says they're allergic to that medication. Sometimes patients will say, I'm allergic to that medication, so I don't want it. But in many, many cases, what they call an allergy is a side effect of the med. So they'll say, oh, it gives me terrible gastric pains if I take naproxen. Well, that's one of the side effects of the med, and that's why we say take it with food and lots of water. So frequently, what the patients consider to be an allergy is often a side effect of the med. And so every now and then, you'll be giving something that you validated with the physician. The patient then says, when you say, well, it says you're allergic to it, but I'm going to give you some, the doctor says it's okay, because you indicated that the reason you're allergic is because it causes gastric pain, or it gives you diarrhea, or whatever. But that's the drug that would be probably best for them, and that's just a side effect of the drug. But do not give it to them unless you've checked. If you know they have an allergy band on and that's the med ordered, now with all of the electronic checking, especially in acute care facilities, generally pharmacy will catch that. They will have cross-referencing of meds and interactions with the meds that are already ordered, so that really shouldn't happen a great deal anymore. Okay? So don't give it to them if you know they're sensitive or allergic to a drug. If they're getting medication, antibiotics, you have to give the doses around the clock. Pharmacy, for the most part, manages the times. It'll show up on the MAR. If it's an antibiotic, it'll show up around the clock. So if it's 4 times a day, it'll show up every 6 hours on your MAR. If it's 3 times a day, it'll show up every 8 hours. If it's once a day or twice a day, whatever, but it's always spaced over a 24-hour clock, so that during the night you'll be giving meds as well. And some of those examples that are listed, the aminoglycosides, the cephalosporins, penicillins, tetracyclines, or miscellaneous other drugs. When patients are getting these anti-infectives for, yes?
Never mind, we were just looking at the card.
Oh,
We just wanted to see, I'm doing some orders.
yeah.
And I was just wondering if we need does it have a DVD VCR player? Sorry.
It does.
It does.
Yeah.
Well, what's wrong with it? It works, right?
Works fine.
Okay, that's the answer. Thank you.
And the bulb's
Okay.
working.
Yeah, we just got to fit. So your job as a nurse, if you're giving these medications and you're trying to address the infection that was causing the fever, is that sometimes patients, especially if they're on aminoglycosides, the lab will order, or the physician will order, or sometimes the pharmacy adds the order, depends on what kind of facility you're working in. They will order peaks and troughs. Anybody ever heard of that? What is that?
The peak is what you check right as you give the medication, and the trough is like right before the second dose.
Yeah.
To give the correct antibiotics for the
Right.
virus.
Correct. So those peaks and troughs are really important, and it's kind of like a 24-hour urine. Nurses just don't seem to be able to get it right. So the peaks and the troughs, the peak is usually the lab comes an hour after the drug was scheduled to be given. So if it's scheduled at 2 p.m., the lab will automatically come up at 3 o'clock to draw a peak. And that's the peak level of drug that's in the plasma at the time, an hour after the med was given. The trough is ordered an hour before the next dose is due. So what do you think the problem is that nurses have, and they don't seem to be drawn at the right time?
They don't give them medications at the right time.
They don't give the meds at the right time. So if you know that your patient's on aminoglycoside, check the labs and see if they have a lab order for peaks and troughs. If it's ordered at 2, you can't give it at 3, because the lab's going to be right on their heels, and they're not going to have, there probably hasn't been enough time for the drug to be absorbed, or it'll be too high in the bloodstream, depending on how it was given. If it's been given IV in a piggyback, it'll probably raise the serum level really quickly. So with oral, it'll take a longer time. So the peak and the trough. The trough, an hour before the next dose is due. So if the peaks and troughs look really weird, then look at what time you actually gave the med. If you know you're going to be an hour late, call the lab and tell them not to draw it until an hour later. You need to communicate to the lab because the physician orders the dose, perhaps the next dose, based on the peaks and troughs, because these aminoglycosides cause nephrotoxicity and cause renal failure. They can also cause ototoxicity, which is loss of hearing. So, again, in some hospitals it is standard. If an aminoglycoside is ordered, you'll see the speech pathologist coming up and they'll do a quick hearing test. That's standard in some facilities, and other facilities it's ordered specifically, but in many places that if it's ordered, they're notified to do a hearing test before they start those meds. So that if the patient loses their hearing, they know at least what the baseline was before the med was administered. It causes nephrotoxicity. I've had a number of patients who've gone into acute renal failure because the kidneys just couldn't handle the dose that was given. So that's the reason they do the peaks and troughs. And you as a nurse need to make sure that you do it on time and that you call the lab if it's going to be late. Okay?
Can you go over the peak again?
Do what?
Peak?
The peak and the trough. The peak is drawn by the lab, and usually an hour after the IV med has been given, because most of these meds are given IV. The trough, an hour before the next dose is due. So the lowest level of concentration in the plasma is the trough. The peak, the highest level of concentration, if that's too high, it could very readily be ototoxic and nephrotoxic. It could be ototoxic and nephrotoxic within the range of normal concentration. So very careful monitoring is done for those meds. A little bit about a thyroid. Where's your thyroid? Yep, it's in your neck, right? It should be palpable, but it shouldn't be visibly. It shouldn't be visible, but without the palpation. So it's in your neck. It's right below the cricoid cartilage, right? And it has a right and a left lobe. And what are those? What does the thyroid secrete? Thyroid hormone, right? And usually on the lab test it's T3 and T4. Okay. There are also parafollicular cells in your thyroid. What do those secrete? Melatonin. Yeah. And it influences what? Calcium regulation. Really, really important. So if you have a patient who has hyperthyroidism, are they going to feel hot or cold? Hot. But do they have a fever?
No.
They could have a little bit of an elevated temp. They could have a low-grade fever if they're hyperthyroid. How about hypo? Just the opposite. They're going to feel cold, want lots of clothes on, and they may have what's an abnormally low temperature called? It may be hypothermic, right? Versus hyperthermic. So with hypothyroidism, they have a decreased basal metabolic rate, which affects the body's temperature. Okay, so if you have a low basal metabolic rate, it drops your temperature down. A high basal metabolic rate due to the thyroid hormone would bring your temperature up. So those patients may have a low-grade fever. Okay. Now we're going to shift. We're going to go away from a fever due to an illness. Now we're going to go to hyperthermia caused by environmental temperatures. Okay? So hyperthermia, hyper too much, thermia heat, too hot, is a dysfunction of the thermoregulatory mechanism where the body is unable to lose heat. Okay, so in hot weather, it seems like almost every year, sometime in August or so, when schools start football practice, what do we hear happen? They die from heat stroke. Yeah, so they're in a really hot environment, lots of activity, they get overheated, and so they die from hyperthermia. Hyperthermia also causes the severe dehydration. There's a lot of loss of fluid before they become hyperthermic. And it could also be due to hypothalamus injury. So those patients you see in critical care with severe increased intracranial pressure will have hyperthermia as well. So different underlying cause. Our main concern with hyperthermia is brain damage because neurologic tissue is irreversibly damaged when the brain temperature reaches 107 degrees or 42 degrees centigrade. So very, very high temperatures. The brain just can't tolerate that sort of hot heat level, and so there's irreversible brain damage when the temperature gets that high. What do some children develop if they have a really high temperature, but not perhaps 107? They have seizures because the brain's too hot, irritates those the neurologic tissue, and it causes seizure activity more in young children than it does in adults. But every now and then you'll come across an adult who has a fever and then suddenly starts developing seizures. Okay? So what happens with hyperthermia? What happens with your level of consciousness? Nothing good happens, right? So LOC changes, confusion, disorientation, restlessness, and listlessness. What's listlessness? Yeah, they're just not hardly moving. Restlessness, they're just moving around and they're confused, and they may just be kind of trying to get out of the bed, crawling over the side rails, pulling out tubes and lines. So we're trying very hard in a hospital, certainly, to prevent hyperthermia from occurring in the first place. Okay? So if you're looking at environmental factors, there are different types of hyperthermia. The first one is heat exhaustion, the very lowest level. Heat exhaustion. And if you can remember, the signs and symptoms are related to dehydration. Okay? So if there's dehydration, loss of volume in your vascular system, you can just look at these signs and symptoms. You get tachycardia. You get dyspnea, hypotension. The skin is moist. There's some sweating. There's fatigue, weakness, hyperventilation. There could be headache, anxiety, nausea, and vomiting, and fainting. Not all of them are present in all patients, but those are the potential signs and symptoms related to heat exhaustion. The intervention, usually the temperature is 102 or less, that's Fahrenheit. So it would be smart to just stop doing what you're doing. If you're out there playing football and it's 110 or 105 and you're exercising very vigorously, then stop exercising, rest, drink lots of fluids, and cool down. So go into a cool environment and cool off. Does that make sense to you? So how do those people survive, like, in Las Vegas? How come they're not all getting heat exhaustion? Because of what? They have swimming pools and air conditioning, maybe. Do you think you get accustomed to living in that environment? Absolutely. So you acclimate to it. It's kind of like acclimating to higher elevation. You can acclimate to a hot temperature. And as acclimation occurs, what happens physiologically? What do you think? Yeah, your sweat doesn't contain as much sodium, so your sodium doesn't become depleted. You don't have those electrolyte changes if you're doing it here in Southern California. And so with a lot less sodium in your sweat, when you're profusely hot and sweating, and you don't lose so much sodium, you don't have electrolyte imbalances, and you don't go into some of the signs and symptoms of heat exhaustion. Okay? But if you have heat exhaustion, you're not living in Vegas, what's causing those signs and symptoms? Loss of salt due to profuse sweating, right, in that heat. So those electrolyte changes is what causes a lot of those signs and symptoms. The loss of fluid causes tachycardia. the fatigue, the weakness, the headache is caused by loss of sodium. So if you just think about the signs and symptoms of dehydration, loss of fluid, okay, during this stage, yes.
Just wondering, out of the topic, when you're sweating like that,
Uh-huh.
you just lick yourself.
You have to catch a lot of sweat to replenish your sodium. So probably not, but it does taste very salty, right? It's like tears are very salty. So no, I don't think that would help, but taking in more fluids would be a much better thing. So that's heat exhaustion. What's the next one we have on our left? So what do you do to prevent this? Rest frequently, drink lots of fluid. Heat cramps is the next level. So if you just ignored all of those signs and symptoms of heat exhaustion, and you're still out there playing football, the next thing, or you're still running a marathon and it's 100 degrees, the next level would be heat cramps. And heat cramps are very painful intermittent muscle cramps. Okay? All of that exercise that you're doing, you're doing vigorous exercise, right? So you're still sweating profusely at this next level. And so you're disturbing the sodium balance even more. So at this point, you've lost a lot more sodium than you did at the first level of heat exhaustion. So with heat cramps, so what's the treatment? Rest and drinking Gatorade, electrolyte-based drinks. Yeah. So replenishing fluids, electrolyte-based fluids, Gatorade, and resting. And so the next level is heat stroke, also called hyperpyrexia. The hyperpyrexia was on that list where we showed all the different temperature gradations. So heat stroke is hyperpyrexia. This is where your body reaches 41 degrees, 41 to 42 centigrade, which is 106 to 108 Fahrenheit. So you can see why these young kids, why the mortality rate is so high. So as the hypothalamus becomes overheated, because the whole body is so hot, it loses its ability to regulate the body's temperature. And that's why it's so dangerous. And so that hyperpyrexia causes damage to your body's tissues, certainly to central nervous system type of tissues, to your brain in particular. And it does so in a matter of minutes. Okay, so if you have the heat stroke, you have that high temperature, and at this point, are they still sweating? No. What does the skin look like? They've already lost all that excess fluid, so they're already dehydrated at this point. And they look very pale, do you think, or do they look flushed?
Dry.
Flushed and dry. Yeah, so they look very flushed and dry. So these patients may have complaints, but they may also have lost consciousness already during this stage. The skin is red, hot, and dry. They may be delirious or unresponsive at this point in time when the temperature of the brain gets to that 106 to 108. And some of these complications are renal failure. How does that increased temperature cause renal failure? Lack of fluid, water. What goes through the kidneys? But is there just water flowing through your kidneys? It's the blood flowing through the kidneys, right? So lack of blood volume going through the kidneys. What's causing that loss of blood volume? Dehydration, secondary to? What caused the dehydration? No? Fluid loss, right? The excessive sweating. So how does that cause renal failure? Okay, why is there not enough blood going to the kidney?
Looking at more, the viscosity of the blood?
Maybe. No? It does become more, if you want to call it, increased viscosity,
Yeah.
thick,
Yeah,
because there's less volume.
exactly. So it's hard
So
to...
why does it cause renal failure?
Wouldn't it be because like the blood shunting towards the brain?
Yes.
Because
Because the kidneys are not,
insulin not the brain.
kidneys
Brain
are
in
not
charge.
The brain
vital organs, right? So the body says, hello, oh my gosh, there is so much fluid loss here. What are your vital organs?
Your brain.
The brain, the heart, and the lungs. Everything else you can do without for a short period of time. So the body shunts the blood away to the vital organs. There's so much loss of volume, that profuse sweating that went on in the previous stage, and now the body temperature is so high that the vital organs are going to get whatever perfusion is available, and it's very limited at this time. So the heart, the lungs, because they have to work together to make them work, the heart or the lungs, and the brain are going to get the perfusion. It's going to bypass the kidneys because it's not a vital organ. Okay, so at this point you can understand why there's such a high mortality rate. The renal system is already shut down. We're trying to preserve brain, heart, and lungs to keep you alive. What causes the hyperkalemia? There's what? The sodium and potassium are inversely related. Okay, and they've lost all that sodium. Yes. Yes. So that's why they have hyperkalemia. And what is the definition of shock? At what point do we consider patients to be in shock? No, you can be unresponsive and not be in shock, right? There are lots of people that we cared for who weren't in shock and they were totally unresponsive to our care. So how do we define shock? And what kind of shock would this be? We talked about septic shock. This would be hypovolemic shock. Okay? Because there was no disease process. The patient just got overheated. So what is the definition of shock? So how do we measure the volume? You're on the right track. How do we know that the patient has low blood volume due to loss of all these fluids in the vascular state? Yes. Decreased blood pressure. And what do you think is the definition of shock? It's systolic pressure less than 90. You guys are doing good critical thinking. See how all these things just sort of work together? Are you confused? Is it making sense? Yeah?
Could be less.
Okay, so shock is, and they would be in hypovolemic shock, hypo too little volume, hypovolemic in the vascular system, which causes the blood pressure to drop, and when the systolic reaches 90 or less, they are in hypovolemic shock. So if they're hypovolemic, what do we try to do? Replenish fluids, absolutely, because already the kidneys aren't getting perfusion, right? Okay, so just to step back a minute before we go to treatment, there are different types of heat stroke. Exertional heat stroke is the kind I just described, the kids who are playing football on a hot day. Has sudden onset, strenuous physical activity in a really hot, humid environment. Why hot and humid? Why is that worse than hot and dry?
Doesn't allow the cooling effect from the sweat.
It doesn't allow the cooling effect from sweating. The whole intent of sweating, your body's response to cool yourself off. If you have 100% humidity, that sweating process is not going to cool your body off. So much worse than hot, humid conditions. The classic heat stroke occurs over time. It's chronic exposure to a hot, humid environment. And this is how some of those older adults end up with heat stroke. They don't really have that sense of how hot it is, right? Because their thermostat and their ability to regulate temperature is diminished due to age. And so maybe they don't have the air conditioning on because they don't feel really how hot it is. That's why during hot days they say check on the older adults, check on your neighbors who are older, because they don't have that sense of thirst to replenish fluids. They don't have that sense of how truly hot it is. And I have been in homes of older adults in July when it's 100 degrees outside and their heater was on. You come in and it's like, and they're wearing a sweater. It's like, hello. And, you know, they're kind of like, aren't you hot? No, I'm good. That's why we have to check on seniors. That sense of heat isn't there. That sense of thirst isn't generated. And so this is how they end up with that heat stroke that occurs over time. Okay? So how do we manage heat stroke? Hopefully, well, if they have heat stroke, often the activity is already stopped because they passed out. They're no longer able to do the activity. So as soon as they reach that max, they will lose consciousness. They sort of lose their ability to function anymore because the brain is so hot. So we want to take them out of that hot environment. If they're outdoors, get them into the shade. If there's some shade somewhere that you can provide for them so they're not in the hot sun. If you're in the situation where this occurs and you suspect heat stroke, and you can certainly suspect that with that hot, dry skin, loss of consciousness, you need to call 911. You can, if you have wet towels or wet clothing, that you could just, if there's water source nearby, to wet the clothing, mix them with water, but you don't want them to shiver because shivering is going to increase the temperature even more. So we don't want them to shiver. They're already totally overheated. And then when they get to the hospital, we will, when they get to usually to the emergency department, we will give them O2. Why are they getting O2? They're in heat stroke. Why do they need O2? More oxygen getting into the system because they already have tremendous shunting of blood away from non-vital organs. We're going to give them cooled IV fluids. How do we cool those IV fluids? Get a basin with ice and lay the IV bags in there and then hang them as the patient needs them. Often they have rapid infusers, but they'll transfer them to critical care quickly. They have what's called rapid infusers. We also use those to rapidly give them lots of blood if they're bleeding out. So they have rapid infusers, and we're going to give them normal saline. Why do we give them normal saline? That's what they lost. All that sodium is gone. Normal saline. Saline is sodium. Okay, so if you're looking for a bottle of normal saline, it says on the bottle sodium chloride. Normal saline is 0.9%. There's also half normal saline, which is 0.45%. Okay, so we're going to give them normal saline, and we're going to probably put them on a cooling blanket. A cooling blanket looks like, like a deflated air mattress that has coils running through it. And you plug it into a machine, and you set the temperature that you want it to be, and ice water basically runs through those coils. And the intent is to get that body cooled down as quickly as you can. To cool the internal, to cool them off internally, we'll often do ice, normal saline, NG irrigation. So they'll put in an NG tube and irrigate the GI system, the stomach, with ice saline, so that you're internally cooling off the GI system, internal organs. And often they'll put them on dialysis. So they're giving them lots of fluids, fast infusion of fluids of normal saline. And why would they start dialysis?
Because the kidneys shut down.
The kidneys shut down, and if the kidneys are shut down, what happens? You get all that metabolic waste that just stays in the vascular system. That metabolic waste can also be neurotoxic. So they'll try to do the dialysis and also use the dialysis to cool off the blood. So they'll set the temperature so that the blood that's they'll take the patient's own blood. Sometimes they're giving them fluids as well, but they'll set the temperature so that the blood we're sending back through the dialysis machine is cooler than body temperature blood. So that's internal cooling as well. Okay. For the patients who are having signs and symptoms or actually diagnosed with heat stroke, what kind of antipyretics do we want to give them? Remember that list of antipyretics? Yeah. So which one are we going to give them? Okay, you know how you have to give the purpose of why you would give the drug? What would be the purpose of antipyretics? Fever due to some sort of organism, right? Does this patient have some sort of organism that's causing the fever? So do we give antipyretics?
No.
Not indicated. We don't give them. Okay. If you're taking care of this patient who has heat stroke, you're going to take their temperature every 15 minutes. What else do you think the patient would need? Think about all the things we already talked about. Patient is now in the hospital. What orders would you anticipate?
Fluid, electrolyte,
Fluid, monitor electrolytes, get electrolytes drawn. What else? Put in that Foley catheter. Why? Because we're giving tons of fluids. Patient's probably unconscious, right? Frequently they are because they have that 106 to 108. And what else? What's another reason for the Foley? Monitor renal output to make sure that the kidney is putting out urine, right? So without a Foley catheter, you wouldn't know that. What else are you going to do? What other lab do we want? What lab did we already order? CBC. Why do we want the CBC? We want to know, are they still alive? Yeah. Sure. Why do you want the CBC? We don't care about the white cells because they don't have an infection, right? They didn't have it before they got overheated. H&H and the RBCs, yeah. Because what would they indicate? They would be very high. Because the more dehydrated you get, the more sodium you lose, the higher those go because you have depletion of volume in your vascular system. What else do we want? Creatinine would be specific for kidney function, yes. BMP, that stands for basal metabolic panel. So you get electrolytes on that, right? Some hospitals have a little difference, but usually it's the basic metabolic panel. What kind? That's a BMP, isn't it? Sort of? Yeah, we want cardiac enzymes. Why? Yes. What other enzymes do we want? Liver enzymes. Okay. What else are we going to give these patients if they start to shiver? What's the drug of choice to stop shivering? You have all the answers in the corner there, so what is it? Muscle relaxant. Okay, tell me why they need a muscle relaxant. Okay. Okay, the drug of choice to give the muscle relaxant is usually Demerol, meperidine. So we only give it if the patient begins to shiver. Okay, so the muscle relaxant is given when the patient starts to shiver. Remember, we have them on cooling blankets. We're trying to get their temperature down quickly. And the body's response to that feeling very cold, especially on the surface skin, is to start shivering. So the meperidine, the Demerol, or the Thorazine is given for shivering. So the muscle relaxant is to stop the shivering. Because if you start to shiver and those muscles generate all of that energy, you're going to increase the temperature even more. So we're trying not to allow the patient to shiver. We're also giving medications frequently to prevent seizures due to the high fever. Okay? And the drug we would give to prevent seizures, you're probably familiar with it. Name a drug that stops seizures. Versed, not so much. Valium for seizures. Okay, and now we've got the patient cooling down. It was 107 when they came in. He's laying on a cooling blanket. There's a cooling blanket over the top of the patient. You, as a nurse, will apply a sheet of some sort, like a bed sheet, between the cooling blanket and the patient's skin. That cooling blanket should never be directly against the patient's skin. There should always be a sheet covering a cooling blanket, okay? Because it gets really cold. We start slowing the cooling measures when the temperature gets to 102 or 39 degrees centigrade. Heat stroke has a really high mortality rate. Many of these folks who come in with heat stroke from environmental type of heat and exhaustion and activity and heat do not survive. Even if they're young and healthy, it kind of gets beyond the level of being able to turn it around. The brain is getting cooked, the kidneys have shut down, their electrolytes are totally out of whack. The blood in their vascular system is really kind of sludge. It's very, very thick from loss of all those fluids. So trying to turn that around is frequently very difficult. Okay. There's a different kind of hyperthermia. It's called malignant hyperthermia. It's a very rare inherited condition, and it's genetic or familial condition. So if you are having surgery, who comes to visit you before you have the surgery? The anesthesiologist. And what kind of question are they going to ask to determine if you have this genetic, this gene, this familial tendency towards malignant hyperthermia? So if it's familiar or genetic, and somebody else has had issues with anesthesia, what would they ask you? Family history. Has anyone in your family, have you or your family member ever had what? Negative reaction to any kind of anesthesia, right? Okay. And usually it's, if they have, they will just avoid those triggers that cause malignant hyperthermia. So the anesthetic drugs, and you don't have to remember those, it's isoflurane, halothane, or skeletal muscle relaxants called succinylcholine. Could trigger malignant hyperthermia. So what happens is surgery starts, they give them an inhalation anesthetic, and as a result of having this genetic type of condition, the temperature goes up very, very quickly. And the temperature can increase 1 degree every 5 minutes till it peaks at 42 to 46 degrees centigrade. So a degree every 5 minutes. So you have to act very, very quickly. And the intervention is you stop the anesthesia and you give them a medication called dantrolene. So 44 to 46 degrees I mentioned, right? Or 42 to 46 degrees. That's 111 to 131 degrees Fahrenheit. Right? Huge. The patient will have rigidity of all of their muscles, and it has to be turned around very, very quickly. And survival depends on early recognition that they have malignant hyperthermia and immediate treatment. When you go to the OR, you will see a cart, no matter what hospital you go to, and it says hyperthermia cart. Years ago, We didn't have those in the OR. I worked in a hospital, and again, it's been years ago, and a young guy, he was 21 years old, developed malignant hyperthermia while having, I think it was this very minor inguinal hernia surgery or an umbilical hernia. It was a hernia type of surgery. Developed malignant hyperthermia in the OR. It was not a teaching hospital. They had to send somebody from the hospital to drive to a teaching hospital that had the drug because it wasn't normally stocked in all the hospitals. Pharmacy didn't have it. And so if you look at the rapid increase in temperature, every 5 minutes, 1 degree, it takes a while to go to another facility, pick up a drug, drive back, right? So needless to say, we weren't able to, the young man was in a vegetative state for the rest of his life. He was transferred out of our hospital. His brain was just so destroyed from the high temperature that he did survive, but was totally in a vegetative state. So not brain dead, but vegetative. Now they'll recognize and give them dantrolene, so remember the dantrolene, okay? That's the intervention. That's what turns around malignant hyperthermia. Okay, what causes these patients to suddenly have this increased temperature? It's the anesthesia causes uncontrolled calcium release within the skeletal muscle cells, and that causes muscle rigidity and acute hypermetabolic state. Okay, so they have a very rapidly increasing temperature, and it has all those signs and symptoms. The mortality rate, when I was my first 10 years or so of nursing, was 80%. So if it occurred, 80% of these patients died. Now it's less than 5%, because if it's recognized, they give them dantrolene, they're good to go. Okay, so the dantrolene decreases the calcium release from the muscles.
But do they shake or anything?
They can, but usually it's the rigidity that's the signal, the more so than the shaking, the muscle rigidity. Okay, there's another hyperthermia called neuroleptic malignant syndrome, and neuroleptic malignant syndrome is an abnormal inhibition of central dopamine receptors in the hypothalamus. It's pharmacologically induced, and it's associated with the use of phenothiazine, tricyclic antidepressants, fluoxetine, and haloperidol. Okay, so the treatment is stop using the causative drug and administer dantrolene. You'll see this in critical care, because you don't see it on med-surg because they reverse it before you ever see these patients on med-surg. So far, so good? Okay, we're going to go on to hypothermia. Talked about hyper, we're going to go to hypo. Okay, hypothermia. The core body temperature is less than 95 degrees, or 35 degrees centigrade. What's the normal centigrade? 37. Okay. And a hypothermia, remember, it's a very vicious cycle. Low body temperature causes your metabolic rate to do what? Increase or decrease? Decrease. Okay, so the vicious cycle is, if you have a low body temperature, it causes your basal metabolic rate to decrease, and that decreases the amount of heat produced by the body, right? Because your basal metabolic rate determines your body temperature. How does it do that? Remember that? Good. Okay, so you have insufficient heat available to your body, and then it slows the metabolic rate even more, and when the metabolic rate decreases even more, it decreases your body temperature even further, which decreases the metabolic rate, which ratchets your temperature down further again. Does that make sense? So Hypothermia, everything goes down. Nothing goes up. Everything goes down. So if that cycle continues uninterrupted, pretty soon you end up with hypothermia that keeps ratcheting down the different levels of hypothermia until you're dead, basically. Okay, so death occurs when your core body temperature reaches 75 degrees. And that's 24 degrees centigrade. Hello.
This is for my clinical group.
Okay.
Before they leave, is that okay?
Yep.
Thanks.
So, Rowena's clinical group, there's a handout up here. My clinical group, there's a map to where you have to park. Don't forget to pick them up. You can,
Say those numbers again.
okay. Death will occur when the core body temperature reaches 75 degrees. Fahrenheit, which is 24 degrees centigrade. Okay? 24 degrees Celsius. Death occurs when the core body temperature reaches 75. If your skin temperature reaches 90, when the skin temperature drops to 95 degrees, what's your body temperature? 98.6, right? So when your skin temperature drops to 95 degrees, that's when you start to shiver. You wouldn't think that you would start to shiver at 95, but you do. Okay, so then if you start to shiver or you don't recover the temperature, if you're hypothermia, then everything goes lower and lower and lower. So the heart rate diminishes, the respiratory rate diminishes, the blood pressure drops, and as the temperature keeps going down, the skin's going to start to look cyanotic. So you're going to have just everything going down. The person, as the temperature goes down, can lose consciousness at some point because the hypothalamus doesn't work. Patients generally, as they reach each level, will have more and more dysfunction. Okay? We're going to take a look at some of those mild and moderate and severe hypothermia. First of all, what causes hypothermia? Whoops. Previous. Cold water immersion. Every year we hear about these folks in Minnesota, wherever, Michigan, they fall through the ice, right? And especially kids, they'll fall in some lake or something and they are fished out. In the case of kids, they frequently, not frequently, but there is a chance that those kids will survive cold water immersion much better than an adult will. So sometimes these kids come in, they're clinically dead, and they will try to rewarm them and resuscitate them with fluids and warming, and they may well survive. Adults, not so much. So cold water immersion. Trying to think of another example. Cold water. Oh, even in the ocean, swimming in the ocean. That woman who was trying to swim from England to France not too long ago, she had to stop because she had all kinds of some sort of bites, stingray bites or something, and she was becoming too hypothermic. Traumatic injury, why does that cause? Okay. Yep. Shock state. What happens with shock? Why does that cause hypothermia? And we're talking about environmental cold now, right? So shock? Yeah? You okay with that? What causes it?
Decreased heart rate, respiratory rate.
Decreased heart and respiratory rate. What does that cause? Lowers your cardiac output, you have tremendous vasoconstriction, and you have that same shunting you have with the hypothermia. Immobilization, what does that cause? Promote hypothermia. You're not moving around. If you're outdoors and it's really cold, So if you get sort of, if you're in the mountains and it's snowing, keep moving. Don't sit down and, because you're going to get even colder. The weather, especially for homeless, extremes of age, that's the young and the old again. Alcohol intoxication promotes hypothermia. I see a lot that I'll still see people drinking alcohol while they're on the slope. And it feels warm as it goes down, right? But is it good or bad? Does it really make you feel warm? Alcohol causes vasodilation, so there's even greater risk of more hypothermia because there's that much more surface area in your periphery that's exposed to the cold. Malnutrition, why does that put you at risk for hypothermia?
Decreased fat.
Decreased fat, so what else? Not enough energy. You need nutrition to... Your what? ATP? Energy for your cells, that ATP? Yeah? So you need energy, and if you're not well nourished, you don't have enough ATP to keep your energy levels up. Hypothyroidism, we already mentioned, and inadequate shelter is the same as for homelessness. They're just exposed. The most common cause of hypothermia is weather, with inadequate clothing or inadequate shelter. Okay, we already talked about the elderly and the young, and this is why they're most at risk. And so what are some of those physiologic effects of hypothermia? It has everything listed here by system. And you can see there's nothing that says increase. Increased specific gravity, yes. Increased blood viscosity. But other than that, it's pretty much everything is decreased. If you can remember, hypo, everything is less than for the most part, except for a few things. Why is the the specific gravity increased? That means what? The urine is more or less concentrated. More concentrated because
You're not putting out in urine.
yeah. We'll get to that in a minute. I'll explain it to you why they have increased specific gravity, because they're dehydrated, but I'll tell you why they're dehydrated. Anybody know why they're dehydrated? When you first get cold, what is your response to getting cold? Before you start shivering. Vasoconstriction. So now your whole entire periphery is vasoconstricted. What happens to that volume? Where is it? Where'd it go? To the core. Aha. So now the heart and the kidneys are getting all this volume coming back, and the kidney says, hello, there's way too much volume here. Let me get rid of some. So you pee it out, right? It makes more urine. Get rid of all that volume. Make sense? Okay, now we're going to talk a little bit more about that. What else is on here that's increased? Why is the blood viscosity increased? Yeah, they just got rid of lots of volume, and now they have hypovolemia, and you have that increased blood viscosity due to decreased volume and increased solute in the blood. So we're going to take a look at how all these things happen. So early signs of hypothermia, all kinds of things, including the slurred speech, the blood pressure, and the respiratory rate initially increase, and you already know why, right? Because when you have early signs of hypothermia, you're cold, you have that vasoconstriction, so you have all that volume in your core, and so what does that cause? Blood pressure and respiratory rate increase to compensate for that. Okay? So when the brain temperature is below, that should say 20 degrees, the body becomes poikilothermic, because 30 degrees centigrade, no, I'm sorry, it's 30. Never mind. It's 30. I'm thinking 37 is normal. Okay. So the body can't control its own heat, and so you become comatose. We'll look at the different layers. Oh, I like this little cartoon. It's so cold you are
Freeze your butt off.
freeze your butt off. Okay, so mild hypothermia. Temperature ranges from 32 to 35 degrees centigrade, so you're feeling cold, you're shivering, you have peripheral vascular constriction. As you get really cold, you have sluggish muscular coordination because you're just trying to just maintain some warmth there. You become a bit lethargic, tachycardia and tachypnea because you have all that peripheral vasoconstriction, all that volume in the core. So you have the increased heart rate and respiratory rate to compensate for that. And then you have, this is where that diuresis comes in. You have cold diuresis. Okay, so the core senses all of this volume. The kidneys say, oh my gosh, the heart's pumping so much faster to handle all that volume. We're going to get rid of some of that. It's called cold diuresis and mild hypothermia. So then, we're now dealing again with dehydration. So you've lost so much fluid, which increases the hypothermic risk, right? Because now you don't have enough blood to keep you warm. And so it impairs your circulation. Okay, so what are we going to do for this? If the person's wet, remember we're talking about environmental cold, they're outside. Give them warm fluid, take precautions against choking if LOC is diminished, and give them dry clothing and put blankets on them. So if you're outdoors, just come on in and get warm by the fire. Moderate, you have further depression of body systems. There's decreased cerebral blood flow, so decreased blood flow to your brain. What do you get? Decreased LOC, perhaps confusion, slurred speech, diminished reflexes. Okay? You also get bradycardia here. Why do you get bradycardia? Everything has slowed down, but why is the heart slowing down? Got rid of all the fluids. With less volume, the heart can only compensate for so long. And there's still vasoconstriction in the periphery. Okay? And you're no longer shivering at this point, and you have some muscle rigidity. And why do you have decreased cap refill? Because your periphery is totally vasoconstricted. Cessation of shivering, and you have some muscle rigidity. We were skiing years ago. We were skiing at Telluride, and it was the worst winter blizzard they had in like 50 years. So we decided, since we'd come all the way to Telluride, that we would ski anyways. I think we're the only crazy people out there skiing. And my husband always went over the edge because he was so cold, he couldn't control his leg muscles anymore, and couldn't control his ski. And at that point we realized that we ought to just get out of this cold. It was freezing. It was 30 below with a wind chill of 50 below. It was like crazy to be out there in the first place. But we didn't want to miss any ski time, so there we were. So what are some of those? And if you're camping and somebody has moderate hypothermia, and there's no one around, just you and your buddy camping, what's the best way to re-warm this person? Body to body. Body to body, yeah. Crawl in the same sleeping bag and make them warm. And cuddle what?
Cuddle buddy.
A cuddle buddy. That works.
Nice little massage.
We won't go there, but...
I would.
Okay, so what are you going to do for moderate hypothermia? We want to rewarm the person, right? So we're going to do active external rewarming for the trunk only. External rewarming. Why not the whole body? Why don't we want to put blankets all over their whole body and warm them up quick? Rewarm slow, but why wouldn't we just put the blankets all over them? Why only the trunk?
Because we don't want all the blood to leave the core right away.
Yeah, what would that do? So if you put the warm blankets on the periphery as well, the arms and the legs, what's going to happen to those blood vessels?
They're going to dilate.
They're going to dilate from the heat, and suddenly there's not enough volume anymore, right? And then all that blood comes back, and now it's cold again. So it can cause even further drop in temperature. Can you get that picture? So you don't want to cause a rapid rise in temperature by doing total body warming, external warming, because that cold blood then returns, and then you have this rebound of the temperature going back down. So it's called reducing the after-drop, the temperature after-drop, by warming up the trunk first. They have forced air warming blankets in hospitals. They're called Bear Huggers, B-A-E-R. That's just a brand name. There may be other brands out there as well. And when we're trying to rewarm the patients, we try not to rewarm them more than 1/2 to 2 degrees Fahrenheit per hour. Okay? So 1/2 to 2 degrees Fahrenheit per hour is the max we want to rewarm them, the maximum type of rewarming. So we want to get some labs on these patients. First of all, establish an IV. We want to make sure that we get some labs and an EKG. What kind of labs do we want? We want blood gases. And what else do we want? Blood glucose. So think about this. So why do we want blood glucose? A lot of glucose was used up when they were shivering, right? That first phase. But why do we want blood glucose now? What is the body warm or cold? Very cold. Do you think the pancreas gets cold? Very cold. So maybe the pancreas isn't working, right? So if they're truly that cold, and at the moderate level, the blood glucose would be high, because the insulin is not being, it's not available because the pancreas is so cold. Okay, that's at this point, but if you have prolonged hypothermia, at some point you'll also become hypoglycemic. Does that make sense? But initially, if you did the blood glucose, you might have hyperglycemia, but over time, as you go into the most severe stage of hypothermia, everything is going to hypoglycemia at that point. So if a patient's not unconscious at this point, what can we give them to drink? Warm fluid. Okay, what kind of fluid? A little alcohol? Some tea? Some hot coffee? Chocolate? Nothing with caffeine in it. Why? Because caffeine is a vasodilator. And you have that rebound hypothermia again. Okay? So the vasodilation would cause further dehydration and further hypothermia. Now we have these people who come in. These are the ones who fell into the lake. They're now severely hypothermic, very life-threatening. Everything is now negative. Okay? And these are the patients who often come in and we can't revive them. They may look like they're clinically dead. They may not have any pupillary responses. They may appear dead. Their muscles are rigid. They are totally bradypneic or very difficult. Their breathing is so shallow you can hardly detect that they're breathing. They have hardly any blood pressure that you can measure. They're so hypotensive. They may not have detectable peripheral pulses, and they have acid base abnormalities. So keep in mind, a cold heart is an irritable heart. Do not turn these patients. The fourth semester, occasionally you see hypothermia patients, people who are lost in the mountains overnight, and they find them the next day, for example. So a cold heart is a very irritable part, and just turning them, they put them into V-fib. So don't jolt them around. And what are we going to do for these folks? If they have a perfusing cardiac rhythm, then we want to warm them up. So trunk hole rewarming first. We're going to monitor their breath sound. These patients are at risk for pulmonary edema. Okay? The airway is secured with an endotracheal tube. Remember, they're unresponsive. You may not even be able to detect the heartbeat. And we do active internal rewarming. So we give them warm oxygen, humidified oxygen, warm IV fluids, warm peritoneal lavage, warm lavage into to the NG tube. They may do blood warming with a bypass machine. These patients generally, like I said, if they're adults, often don't survive. So we're trying to rewarm them. We need to monitor for complications. And one of the complications is rewarming shock. So again, we rewarm the trunk area first. Keep them still so we don't initiate ventricular fib. And again, if they do go into fibrillation, you can't defibrillate a cold heart. So if the temperature is less than 86 degrees, you can't defibrillate. Okay? These patients need to be rewarmed. You can't pronounce someone dead until they're warm. Okay? You can't pronounce them dead while they're still cold. So no one's dead till they're warm and dead. We have to rewarm these patients. This is in the case of severe hypothermia. We know that that's what the reason is for them to be unresponsive, unconscious, okay? If you find someone dead in a home and you know it's not due to hypothermia, you have to warm them up. That's just for severe hypothermia. So, in that case, no one's dead till they're warm and dead. Okay. What's frostbite? What's frostbite? Yeah, freezing of the fluid in the tissue, the cells, the fluid in the cells are becoming frozen. Okay. So if you have just minimal frostbite, first degree frostbite, what is your extremity? Usually it's feet and toes and fingers and nose and ears. Okay, so first degree frostbite, you look red, hyperemia. The skin looks red. Second degree frostbite, you have large fluid-filled blisters. And some partial thickness skin necrosis. With third degree frostbite, you have those blisters and they're filled with dark fluid and the body part is cool. It may be numb, it may be blue, loss of sensation. And then the fourth degree frostbite, the entire part is numb, cold, it's bloodless, and the necrosis extends into the muscle tissue and the bone. So they often amputate if it's totally frozen. Okay? And they usually have to amputate if gangrene sets in. Once that tissue is frozen and dead, you can't resuscitate it. Okay. I forgot to mention, when you have hypothermia and you're in severe hypothermia, if you're still conscious and you're cold, moderate hypothermia, and if you're lost in the snow, there was a family a couple of years ago in Oregon. They ended up on a road that was closed. Anybody hear about that?
Yeah.
The two kids, the husband and the wife, after burning their tires, taking the tires off the minivan and burning their tires and trying to keep warm, their cell phones didn't work. The husband left and was going to look for help, got disoriented, and the wife and the kids actually survived and they were found. But due to privacy type of laws, they weren't allowed to go to the phone company to find out where the cell phone was last used. At any rate, they found the husband, but they found him, they found the trail, they finally did get approval to search those telephone records. But they found that they found his gloves and his hat, and then they found his jacket, and they found his clothing before they found him. Why did he take his clothes off? What's that called? It's in your book. No, there's a reason why it's called something. What's it called? But you hear that, like there was somebody lost on Mount Everest some years ago, a surgeon, and they found him as well. He had discarded all of his clothes and did end up showing up at the tent where some of his fellow hikers were. They did re-warm him. He did lose all of his fingers, all of his toes, his nose, and his ears. There's no longer a surgeon, needless to say, but he did survive, but he had discarded all of his clothes too. Why do people do that?
Your body gets hot.
No, body doesn't get hot. The body has another set point. The brain is so cold that at some point the brain sort of resets, and then the mind says, I'm not so cold anymore. But it's at a very, very low set point. So they take their clothes off. It's called paradoxical undressing. Paradoxical undressing. That's why when they get to moderate to severe hypothermia, they'll take their clothes off, and that's why we find those folks when they are found. The ski jackets are taken off. Everything they wore that would have protected them is removed. Because they then have this false sense of, oh, now I'm feeling warm, and so they discard their clothing. Okay, in terms of frostbite intervention, rapid rewarming in a water bath of 104 to 108 degrees. So never hot water, warm water. Your body temperature is normally close to 99, so 104 to 108 degrees. Dry heat should never be applied to an area where you suspect there's frostbite, so no heating pads ever of any kind. Always in a warm bath. And sometimes people think if they just rub the area that is frostbitten will help to get some circulation going, causes tremendous damage to the tissues. So there should be no massaging or rubbing of the affected part. It produces further tissue injury, and that may cause the whatever is frozen and frostbitten to be amputated. We administer analgesics and IV fluids and IV antibiotics, and hopefully we'll get some circulation going to save the limb. Okay? This is pretty much self-explanatory. We do want to immunize for tetanus. Tetanus is given because, why did they give these folks a tetanus shot? Because frostbite damages tissue, right? And so if you have deep tissue necrosis means the tissue is dead. It makes the tissue prone to tetanus, so we always give them a tetanus shot. You're going to learn about compartment syndrome more so in Module 9, the next module, but who knows what compartment syndrome is? What can you have? Where do you have compartments in your body? Compartments are compartments that they're surrounded by fascia, and what's in those compartments? In your arms, in your legs, and in your abdomen. What's in there? What runs through compartments in your body? Compartment syndrome says. Connective tissue, fascia, and compartment syndrome is too much pressure within those compartments, putting compression on nerves, blood vessels, due to edema. So if you have hypothermia, if you have frostbite, there could be edema due to the damage to the tissues. So the compartment syndrome, abdomen, arms, and legs.
that like the extracellular fluid? Does it come out from the cell?
Yes.
Okay.
And then the compartment is kind of like your skull. It doesn't expand. It's connective tissue. It's fascia through which all those nerves and blood vessels run. So if there is swelling in the tissues, it puts pressure on the blood vessels and nerves. It's very painful. And so you're always assessing for compartment syndrome. Okay. I think the rest of the slides are all nursing diagnoses. Yep. Okay. So, did anybody remember to do the case study or no? Yes? How many? 6 of you. Okay. If that's the case, I'm going to give you a new one that's relevant to this case. And if the rest of you get the other case study done, we'll go over it when you have it all done. This is relevant to this module. It's still very hot in here. So I want you to think about a patient. Let's say next week you have a patient who is a post-op patient. Nope, that's only in the OR. Who else needs one? Okay, so next week you take care of a patient who just came back from the OR. Let's put this into perspective. The patient has a temperature of 98 degrees. The patient's kind of borderline hypothermic. Okay? And the patient comes back with a blood pressure that is sort of borderline, kind of like maybe 100/60. You get the picture of the patient you have? So the patient comes back to the floor, you check them in, the OR nurse brings them, gives you a report, and so one of the first things you're going to do is assess them and take vital signs, right? Because you need a baseline. So you got that 98 degree temperature, and the blood pressure, what did I say, the systolic was about 100, right? So now, one of the things that you do for a post-op patient is warm them up, and they have blanket warmers to warm up a blanket, so you can make them warm post-op. Yeah?
Yes.
Okay, the blanket warmers they have like bath blankets, and they're like flannel blankets, really nice and warm blankets. Don't warm it up in a microwave. Patient wants a warm blanket, you don't have a blanket warmer. Don't warm up the blanket in the microwave. The fire department will come out because the smoke will be such that with the blanket on fire that you have to call the fire department. Yes, that's happened too. Not a good thing to do, so no blankets in the microwave, please. Note to self. Okay, so now you're going to put some of those warm blankets on the patient. Yes, everybody put the blanket on the patient, and now you're going to take vital signs again. What do you think happened? What happened?
The heart rate, the right
Why?
Vasodilation,
Vasodilation.
so it brings the blood pressure
Down even further, so keep an eye on those patients. Now that you know the mechanism of peripheral vasodilation with warm blankets, so keep a really close eye on those post-op patients who are already borderline. So it's not so much that their temperature came up.
I think we have the wrong thing. Do we have the wrong? This is a stage 4 pressure, 88-year-old constipated lady.
We have a constipated lady.
I thought it was Ava.
You should have Mrs. Gilroy.
Yeah.
Yes, I'm just telling you about the patient you might see next week. I just wanted to know if you could do some critical thinking. What would happen to your patient? Okay, let's talk about Mrs. Gilroy. We're going to combine all kinds of things. Module 3, because she's a senior. This current module as well. And all kinds of things that we've already learned. Because the patients that you're going to see have all kinds of things that are combined, and it's not just, oh, now I have a neuro patient and now I have a respiratory patient. It just doesn't happen that way. So here you have this 88-year-old lady. She was admitted with dehydration. So what were her labs? What would you expect on her labs if she was admitted with dehydration? So what? High specific gravity in her urine, but what would be her lab? What's elevated? Sodium. What else? H&H. What else? Not the whole CBC, because CBC includes white cells, RBCs, and H&H, right? Okay, you got to keep remembering all the stuff you learned because we're going to build on all of this information. So, she has a stage 4 pressure ulcer on her sacrum. What does that tell you about the patient? What comes to mind? She's not moving, has probably been chronically ill and bedridden for a long time with a stage 4, right? Okay. What else does it say about her? She has a pressure ulcer. Oh, she has a wet to dry dressing on her sacral ulcer. A pressure ulcer with eschar in her left heel. What's eschar? Sometimes it's black, yellow stuff. Eschar is dead tissue, right? But we never take it off of heel. Because once you take that, it's still sort of protective. You never take eschar off of heel. Usually that leads to the need for amputation. So just remember, we'll take eschar out of every wound except off the heel. She weighs 90 pounds. What does that tell you? She's probably malnourished, so what lab would show that? Albumin would be less than 3.5. Okay. So now she refuses lunch. They started an IV. When you come on, she has 750 cc's of credit in her IV, meaning the shift is ending with 750 left. She's a sweet little lady, quiet and at times forgetful. Her admission labs just came in. Her hemoglobin is low. Hematocrit is low, but that's probably due to age and dehydration and malnourishment, right? Her white count is high, and her potassium normal is 3.5 to 4.5, so it's borderline high. And the nurse says, I haven't called the physician. So now, you're going to look at what's been ordered for her, and you can interactive activity, use the case study and the flow charts to identify the pertinent patient information that you got in report. Okay? And then what information you're going to gather from the flow chart and what you're going to follow up on. Okay, what do you remember about older adults and WBCs? They generally don't have high WBCs. Hers are high. What's the normal? You were supposed to remember the normal WBCs. 4.5 to 10.5, right? 4, 5 to 11, depends on the lab. Hers is how much? 11,000, okay? So that's pretty high for someone who's an older adult, because normally they'll stay within that range of normal, even though it's elevated. So you have to look at the trending. Okay. when are WBCs critical? What numbers? Remember that one? Greater than 30,000 and less than 2,500. Okay, so what did you put in the first column? What's her diagnosis? What did you get from report? She is dehydrated. What else did you get from report? Put everything you got from report in there. Weighs 90 pounds, has a sacral pressure ulcer with a wet to dry dressing. From when we learn to do dressing changes, what is the purpose of a wet to dry dressing? Remember we taught you dressing changes, sterile dressing? What did we say about wet to dry dressing? Yes, and what's the other piece of information? Research has shown that it's not a good thing to do anymore, so we shouldn't do wet to dry dressings anymore for debridement because because you're carrying out, when you're carrying out the dry dressing for wet to dry, the healing tissue as well, the new skin cells, the little buds that you'll see on the skin. So wet to dry, you still see it ordered, no longer recommended. It's kind of like that saline in the trach. People will come around sooner or later to not doing wet to dry dressing. Okay, and the lab data should go in there. So what are you concerned about with the lab data? Okay, hemoglobin normally is 12 to 16, right? So hers is low. And hematocrit usually 37 to 47. If you know the hemoglobin, you just multiply times 3, and you'll know the hematocrit. If you know the hematocrit and not the hemoglobin, divide it by 3. Okay, so from the flow chart, what are you going to find? How often are her vital signs? Okay. She's hard of hearing.
She needs a pureed diet.
She needs a pureed diet. What size IV needle does she have? What does that tell you? Is that a large needle or a small needle? Very small. So what does that tell you? When they put that in, they only could find a vein using a 24 gauge needle because she was dehydrated. Okay, what else? Okay, she's getting D5. Is that what you said?
Yeah, D5
Okay.
DNR.
She's a DNR, yes.
She's constipated.
Yeah, wouldn't you be constipated if you were bedridden and dehydrated and malnourished? Okay, so what needs follow-up? Okay, labs. What else needs follow-up? What do you have to do every 4 hours? Vital signs. What does she have on her skin? Pressure ulcer, so you need to do a head-to-toe skin assessment. Maybe she has pressure areas elsewhere. Okay, what are you waiting for? The labs, right? Okay. When those labs come back and they're abnormal, what are you going to do? Call the physician. Okay, what else are you going to assess for? Because the lab shows she has a white count that's really elevated for an older adult. And where might that infection be? The wound site. Okay. Alrighty, so at 4:30, and as you leave the report room, you prioritize your plan of care for the next 4 hours. What are you going to do first? Vital signs, so you can perform get a baseline, right? What else are you going to look at? Look at her wound. These are all the things you're going to do next week. This is your patient. You're going to come to the bedside. What are you going to check?
The IV site.
That's the IV site, yes.
Actual IV.
And what?
The actual IV.
Actual IV itself. Is it the correct IV hanging, the IV solution? Okay. Orientation. I'm sorry?
Never mind. Part of it.
Okay, anything else? You may want to reposition, and certainly not on a stage 4 on her decubitus ulcer, right? So she may have to be turned just to the side, and not on her back.
Check if any meds were ordered.
Okay, check to see if any meds were ordered. Does it say anything about output? She was incontinent. So what do you need to check? Check the diaper, make sure that she's not wet. Okay, and then at, let's say you get your lab back, what are you going to do then? If they're abnormal, what are you going to do? Notify the physician or your charge nurse or the nurse you're working with. And sometimes you're the first one to see labs because the nurse hasn't had time. They have multiple patients, you're only going to have one. Okay, what else are you going to do? The next 4 hours. So you started with vital signs, checking the decubitus ulcers, checking the IV site and the IV fluid, checking for incontinence. What are you going to do next? Notify the physician of the lab results. Anything else? What time is it when you come in? This afternoon, so it's like PM shift.
Encourage her to eat dinner, maybe?
Encourage her to eat dinner, okay? You already said you're going to turn her every 2 hours, but not onto the decubitus ulcer. Okay, pretty well every 2 hours you're going to check, turn, right? Check for incontinence and turn. And then at 8 o'clock p.m. at 2000, the nursing assistant says that she is restless and trying to get out of bed, and then you have the following assessment findings. Her speech is incoherent, her skin is warm and flushed. Her vital signs are, temp is 101, is that okay? No. Heart rate's 92, is that okay? Kind of the high end of normal. 100 would be tachycardia, and respiratory rate's 24, and her blood pressure is 108 over 60. She's incontinent of dark-colored urine with a strong odor. Yeah. And what's the dark-colored urine mean? Dehydration, right? And the foul odor, or strong odor, is indicative of a UTI. Yeah. Okay. You call the physician, and then the physician says, catheterize her for post-residual urine. What do you remember? How do you do that?
Urinate.
Have a urinate,
Urinate.
put the catheter in, an in and out cath usually,
Measure her output.
and you're checking to see what? What are you checking? How much is left in the bladder? That's post-residual urine. Post-voiding, and then what's left. Okay, but didn't it say she was confused, getting restless out of bed? She's incoherent speech, so she may not be able to urinate when you ask her to. Her vital signs are every 2. She's now put on INO. What does that mean? You take an output, give her Tylenol for a temp over 100.4. So what's the temp? So you're going to give her Tylenol?
Yes.
Okay. put on the vest posy restraint. What do you remember about posy vest? The V in the front, right? Because if you put it in the back, you can strangulate, the patient can strangulate herself. Okay, encourage fluid intake, how much?
2 to 3 liters.
What's the purpose here? To rehydrate, and she's going to get more dehydrated because she now has a temp, right? What else? What else are we giving her? Rocephin. Okay, and Rocephin is indicated for, usually it's for UTIs and skin structure infections. Okay, it's a very broad spectrum antibiotic. Okay, so what are you going to do first? What requires immediate follow-up?
Give the Tylenol.
Give the Tylenol. Yes, and what else?
Put the clothing on.
Immediate. Administer the Rocephin. You don't want to wait 3 hours to give the antibiotic. The Tylenol and the antibiotic would address the potential UTI or skin infections. Maybe she has an infected decubitus ulcer. Tylenol will bring the temp down. And then what are you going to delegate to a CNA? Vital signs every 2 hours? What else? What do you have to do? You've got 6 other patients. What else can you delegate to the CNA? Encourage her to give her frequent water. How much you're going to tell her? You're not going to have her drown herself in 2 to 3 liters in the next 2 hours. So how much would be a good idea to give?
8 ounces.
8 ounces? How often?
Every half an hour.
Yeah, or if she's pretty old. You don't want to put her over the edge of CHF. So if you gave her she already has IV fluids running too.
Every hour.
So every hour, an ounce or 2? That's 60 milliliters plus the IV fluid. That's a pretty good amount for someone who's 88 years old. Okay, what else are you going to ask the CNA to do? Apply the restraints. What kind of restraints need to be applied? A posy. So you're going to go back to the bedside and you're going to check to make sure that posy restraint was adequately applied. What are you going to check?
The V's
in the front.
On the bed.
It's tied to the bed frame. And how is it tied to the bed frame if it doesn't have those clips?
Just release.
Quick release knot. They can be released with one pull. Okay. All right. So write an expected patient outcome. What is your big concern here?
Fever and infection.
Temp, dehydration, so fluid volume, right? You want to maintain optimum fluid balance, and how are you going to do that? So what's the patient's nursing diagnosis? Not risk score, she's already dehydrated, so what's the nursing diagnosis? Fluid volume deficit related to dehydration is a sign and symptom as evidenced by. What's the cause of the dehydration? What do you think happened to her? Is she bedridden? Based on her decubitus ulcer, she's probably just bedridden. So what do you think was the cause of her dehydration? No. More specific. The answer was malnutrition. Yes, she's malnourished as well. No? What cause? The related to is the cause of her dehydration. What do you think caused her to come into the hospital with all the signs and symptoms of dehydration? It's so simple. lack of adequate fluid because she's probably bedridden and can't get her own, she's forgetful.
That would be your,
As evidenced by is that she, that's the cause of her dehydration, all related to why she didn't get adequate fluid. So as evidenced by, how do you know she has fluid volume deficit? What's the evidence of fluid volume deficit? Skin turgor? I'm sorry? Skin turgor? Yes. The what? LOC changes? Dark urine? Yeah? What else? What are those labs? that tell you that the patient's dehydrated? You have a high sodium, a high BUN, and usually a high H&H, but she's malnourished and she's older, so, and malnourished, so she doesn't have a high H&H. Do you know why she doesn't? Okay, see all the things we talked about? We talked about safety with the restraint. We talked about how to treat her temperature, how to treat her dehydration. We also talked about the assessment findings and what it means and the priorities to get that temperature back down, giving the Rocephin and taking the, giving her more fluids, giving her Tylenol. Whew. So you're going to have these patients, and you have to put all these parts and pieces together. No one comes in a neat little package where they hand it to you and say, this is why your patient's here. Have a great weekend. Don't forget to pick up your Kaiser parking instructions if you want them. My clinical group. Veronica, oh, there you go, from the office. Okay, in a second. Yeah, I have to go get it on Friday, tomorrow. Okay, good. Yeah. Okay. Bring it Monday. Good. And I think I'm marking absent. Yeah, that's what I was going to tell you. Here we are. Carrie's not here. Linda showed up. You still want to go? Yeah. Okay.